So I did not hit record when I did this PowerPoint. So it's going to be nice. I can make it into a small micro lecture, which will actually be a little bit better to understand, I think. When we talk about trauma and we talk about injury that is pretty intense, we need to kind of look at this lethal triad of complications that can happen. So we have coagulopathy, right? How our blood clots, we have acidosis, and we have hypothermia. We know that these three things are can exist alone, or they can exist in conjunction with one another. So before a patient gets to the hospital, and I'm going to use the ER a lot as reference because if they're having a trauma, and most of the time they do get delivered to the emergency department, we're going to count on our pre-hospital team. So these are your paramedics, these are your life flight team, this is your um, volunteer fire department. So we're going to count on them to identify what the injuries are, to do some rapid interventions to try to stabilize the patient, and then get them transported as quickly as possible. By doing that, we are trying to prevent this lethal triad from happening or lessen its effects. So one of the main things that they're going to do in this pre-hospital care is they need to decide if this person is going to a trauma center or whether they're okay at the local emergency department, whether or not Life Flight has to meet them or a medevac needs to come to wherever this is, whether even if they do need to be sent somewhere else, do they need to come to the closest hospital to be stabilized before they send them out? So when we are looking at trauma itself, we're talking about these type of things. So we're thinking of penetrating injuries, things that have punctured, right? Things that have cut in through. These are our gunshot wounds, our knife, our shrapnel, our farm injuries where we've landed on equipment and are impaled. We have spinal cord injuries, anything with a fall or internal capitation, a crushing injury, major burns, and anything that has to do with the compromising of the airway. So, what we do is we look at these body regions and then we assign a score to it. And so we do a quick head to toe. Obviously, we're going to go primary, secondary survey here in a second, but we look at the body systems and we very quickly give them a score from minor, meaning it might be an abrasion or something, that needs to be looked at eventually, all the way down to an unsurvivable. So then we give a score that kind of guides us. Now, this doesn't necessarily need to happen on a one-on-one basis when you're taking care of one client, but if you have a bus accident, say, and you've got 20 people that are coming to you, this is a very quick way to kind of do a severity score so we can prioritize care. So the first thing that you're going to do is, I'm going to try this aside here, is an ABCDE, right? So this is your primary survey, or we call it your primary trauma assessment. And this is where we're going down your basics. So your airway, breathing, circulation, disability, exposure, or environment. So our airway, we obviously want to make sure that this patent, it's maintained. And we need to do this while maintaining C-spine stabilization. So we're going to assume that unless we were right there and saw the injury happen, and we can know 100% certainty that the neck is not damaged, we're going to assume this person needs to have C-spine immobilization. We need to put the C-collar on. We need to make sure we're holding them, we're taping their head to the blocks, whatever we need to do, so that we then do the jaw thrust more than we do the chin tilt when we're looking at your airway. Breathing, we want to make sure we have equal chest rise, make sure that we don't have a collapsed lung, which is a pneumothorax, make sure we don't have something that's intervening. We don't have fluid or bleeding or something that's happening in the lungs. Circulation, again, looking at the skin color, the temperature, cap refill. Cap refill is a very simple way to assess what's going on in the body, even without looking at a blood pressure. If I squeeze my finger and I have a cap refill of less than 3 seconds, I can pretty much guarantee that we've got some peripheral circulation, right? Looking at any signs of obvious bleeding goes in that category as well. Disability has to do with mental faculties, their neurovascular status. Are they awake? What's their GCS, their Glasgow Coma Scale, their level of consciousness? Are their pupils equal? Are they reactive? Do they react to stimuli? And we use AVPU as a quick tool. Are they alert? Are they responsive to voice? Are they responsive to pain? So if their eyes are closed and I rub their chest and I say, "Hey, are you okay? Can you open your eyes for me?" And they open their eyes. Or if I'm using my sternal rub and the only thing I get out of them is a mild groan, right? I don't, they're not waking up if I'm shaking them, but if I do some type of pain, pressure on the nail bed, something like that, they're going to respond, maybe not even verbally, but there is some reaction, or if there's no response whatsoever. And then looking at their person. So we don't always want to tip them over and look at their back and their front. If it's, obviously something that is a gunshot wound or something that gets a through and through, we need to see that eventually, but we have to make sure the airway, breathing, circulation, make sure all that stuff's done before we move them, undress them, see what's going on. Here's a nice chart, and you can kind of enlarge this if you want to on your PowerPoint, but it breaks down that ABCDE with what are you looking for? What type of intervention would be appropriate for that deficit, and then what our goal is. So, this is a really good slide to look at, really kind of dials in on the things that you need to know. So, yeah, I really like that. Our secondary survey then is only completed after we do the first one, only after we have everything stabilized. Then we're going in and getting some more information, right? So then we're going to talk about what are your allergies? What are you taking? When did you eat something last? All that type of thing. This is important in the E for events leading up to injury. So say you have somebody who came in from a car accident, right? So once they come in and they're unconscious, right? So we go ahead, we do our ABCDE primary survey, we get them stabilized, they regain consciousness. Then we go through and say, like, hey, what led up to this, right? Did you get in a car accident and it knocked you unconscious? Or were you, having a terrible headache and all of a sudden, like, you lost your vision and you became unconscious, and that's what led to the accident? So those are the type of things that we need to kind of focus in on, but we have to do it in a priority fashion. We got to make sure you're stable before we can get the information. If there's somebody who saw or witnessed the event or is able to provide that information, absolutely, you can do it concurrently. One person take care of the patient, one person get the information, and then we'll share. The things that we are looking for that are the most critical interventions in this trauma, and we call it the golden hour of trauma. It's the first 60 minutes is where we have the greatest ability to stabilize and to treat them in a way that's going to have a positive outcome, right? So golden hour is what you're going to hear. We want to do life support, if that involves CPR, if that involves advanced airway, managing the airway, doing whatever you need to get that A done of the ABCs. Immobilization, again, very important. If they need to have their neck immobilized, if they have a broken femur, that maybe it is, the largest bone in your body is a femur, right? So if you break it, you have a risk for blood clot, fat embolism. So we need to make sure that's secure. Whatever we need to do to keep whatever injury from getting worse. All right. If the patient is wearing a helmet, whether they came from a motocross or a motorcycle or a football or whatever it is, if at all possible, we're going to leave that in place unless obviously their airway or something is compromised. But we have special tools that we can use to extract and take apart helmets in the emergency setting that is going to minimize any trauma on the neck. So, and we can again always use that jaw thrust instead of the chin tilt when we're trying to keep the airway patent. And then we can always advance, go back to that first part there where they manage the airway and do an advanced airway if we need to. So we always have a workaround that will minimize injury. And then what we just talked about previously about shock. The different things we're going to use are crystalloids versus our colloids, our blood components, making sure we use vasopressive medications or inotropic medications to treat the hemorrhage and the shock. Sometimes when we're looking at somebody, right, and we see a drop in the hemoglobin and hematocrit, but we don't see actual bleeding, we may need to do something invasive. We need to maybe figure out where it's coming from. So they have low blood pressure, their heart rate is high, they have no obvious signs of bleeding, right? But there's something going on. So we can do something. We see they're in shock. We're going to treat the shock, but we do need to locate the source. So we can do x-rays, ultrasound, we call it a fast exam. And that is instead of doing, your fetal growth type ultrasound, this is a quick ultrasound. We're going to go over major points, your spleen, your abdomen, maybe the kidney, the liver, and we're going to look for bleeding and see if we see any gray, we see any free fluid that'll let us know that there's an emergency intervention that needs to happen. And that could even be the surgery. If surgery is warranted, we're going to either transfer to where they need to have the surgery to a higher level of care, or we can go ahead and take them and try to stabilize them locally before we send it, or maybe it's something we can fix where they're at currently. This is not the time to try to track down the family and make sure they get consent and like chit chat about it. And I know that we talk about how feelings and education are very important. But in this case, we're not going to delay care. We're not going to, make sure the family feels really good about it before we go, because we're really trying to make sure the patient is stabilized. So this is where we tell them directly, this is what's going to happen. If you don't have time to explain it because you need to be with the patient, then you have a social worker, case manager, charge nurse, somebody who's able to stop and explain, but you don't compromise patient care or delay it in order to make sure that the family's up to date in what's going on. Another thing I'm going to bring up here is forensic consideration, because if you think about trauma, a lot of times it has to do with something that will have some legal ramifications. Okay, so this is your motor vehicle accidents, this is your gunshot wounds, this is your stabbings, this is your injury caused by something that was not a true accident. So when that happens, in the midst of trying to keep them stabilized and keep the family up to date and try to get all the information you need, this might not always be in the forefront, but it's something we need to think about. So, keeping our evidence, maintaining the chain of custody of evidence, meaning whenever I take off that person, I'm going to try to preserve it so that it can then be used and analyzed. But I also want to make sure that it's never out of my sight. We don't lose track of it. So, when we cut off clothing, we want to make sure we put it in a brown paper bag or something that is breathable, sealable, but breathable. Anything you find, any weapons, any drug paraphernalia, anything that would be dangerous, you want to make sure it's labeled and then given to the authorities. Anything that has markings on the skin, powder residue, hole marks, stab marks, anything like that, as you're cutting off, because we're going to cut off their clothes, right? We got to do a whole trauma panel. We want to get them open up to the skin so we can assess the injury. Anything you cut, you want to make sure you try not to cut through those bullet holes. Anything on their hands, whether that might be tissue, might be powder burns, might be defensive wounds, anything like this. We sometimes will kind of cover their hands as long as it doesn't, interfere with care, obviously, to kind of preserve the evidence till law enforcement can get there. And we're going to use something like this little diagram, and we are going to mark everywhere we find a wound, right? So if you have somebody who comes in a motorcycle accident and they have a road rash from like their shoulder to their knee, you're going to note that. You're going to also look at the back, right? If you have an entry wound, looking for an exit wound, something like that. So making sure, and they have this in paper charting and they have this in computerized charting also, where you click on the little man or woman or person and you make the little notation of what it is. There's a drop down. It says abrasion, laceration, burn, ecchymosis, whatever it is, so that you can adequately get a good description. So make sure that whatever you take off, that is preserved to the best of your ability. Make sure you document to the best of your ability, and make sure that you are maintaining that chain of evidence till it comes to someone, because until law enforcement gets it and they're responsible for it, you would hate to have something be a pivotal or critical piece of evidence that is not admissible or is degraded, or something happened to it simply because of the hustle and bustle of the trauma itself. So our nursing priorities, while we're involved in these type of emergent situations, is we always want to maintain that airway clearance. We're always going to maintain a level of consciousness and noting changes in that. Many times we have dirty wounds. Maybe we have car accident where we have dirt and grime and things in it. Maybe we have um, some type of a fall that caused a trauma, maybe with an open fracture, something like that. So we want to watch for infection, also cross contamination. So again, if you have an abdominal wound and you have a chest wound, you don't want to get any feces into the chest wound and proliferate an infection there. We also want to look at tetanus, right? So tetanus vaccine or tetanus shot. We got to make sure that we're on top of things like this. We're going to promote physical mobility, and that has to do with what they're able to do and compensating for the deficit. So if they're going to be in a cast for a real long time, we're going to make sure that we get them on some type of blood thinner to prevent clots. If they're going to be having some type of a chest surgery or chest involvement, we want to make sure that they're still able to breathe so that we don't end up with pneumonia, those type of things. Maintaining active or passive movement to make sure that we promote circulation and mobility once they do get better. If for some reason we are not successful, we do need to make sure we're prioritizing discussions of organ donation, follow-up counseling, going into teaching coping strategies, trying to make sure that we are caring for the family, as well as the patient if they have a loss of limb or loss of function, or maybe some debilitating long term. We want to make sure that we are encouraging them to talk about it and getting them the strategies, the coping, and the tools we need as far as long-term counseling, spiritual guidance, whatever we need to do, PT, OT, speech, those type of things that we don't just kind of leave them there, but kind of talk them through the process. In your book on page 302, there's a case study and it has to do with a patient with multiple injuries. It's pretty good as far as laying out assessment data, what to recognize, nursing interventions, prioritization. So take a look at that. It kind of gives a good overview of what to do with someone who doesn't have a very cut and dried, simple one body system injury. We're going to talk a little bit about crush injuries, which are a pretty common type of injury. This can be your hand. This can be more commonly it's your forearm and your leg, but anything that could be crushed. We have a couple things that go with it. We're going to talk about compartment syndrome, rhabdomyolysis, and then the two things that we talked about in shock previously, but they do work with this as well as metabolic acidosis and hyperkalemia. So compartment syndrome, anytime you have a circumferential injury, any type of impact can cause a swelling in the compartment of the muscle, and you can end up with pain, swelling, paresthesia, all that type of thing. And we're going to divide it into 6 different categories that you're going to look for. So on the left, you have paresthesis, pain, pallor, pressure, paralysis, and pulselessness, right? What I want you to understand is that that numbness and tingling, my foot's asleep, my hand's asleep kind of feeling is one of the first signs of compartment syndrome, progressing then to an absence of pulse or a super weak pulse. So just because it is just numbness and tingling, we don't kind of dismiss it, right? That is an early sign of compartment syndrome. And how they test for that is they take a manometer, which is they call it a Stryker needle, right? And you insert that down into the compartment and you read the pressure within that muscle segment. So anything less than 30 is going to be elevated. We want it between 0 and 8, ideally. Less than 30, it's elevated. But when it reaches above 30, it actually can cause ischemia because it cuts off the blood supply. That swelling can then cause tissue damage. Okay. And you can see in this picture here on the left, you can see the leg is very shiny. You can see it's very swollen. Those are very common signs of compartment syndrome, is that swelling in between. One of the main things, and it's asterisked and underlined, if they have pain that is disproportionate to the injury, right? You're looking, you don't really see anything, but they are saying it's just, horrible, agonizing pain, especially if it's in the arm or the leg. We want to think compartment syndrome because it will take a long time for that pressure to then extend to what we can see, but it doesn't mean that pressure isn't building on the inside. If we see something that is swollen like this, or we do suspect compartment syndrome, we're going to go against everything we've heard so far in nursing school, right? We are not going to elevate the swollen area because we've already got pressure within that. If we lift it, number one, we're going to increase the pressure as we lift it. Number two, we're going to kink off what circulation they do have. And that can cause more muscle damage, which can cause more trauma. So definitely keep in mind if you have something that you think might be compartment syndrome, keep it level with the heart. Okay, don't try to elevate it. What they do to resolve the pressure is they do what's called a fasciotomy, and that is where they will slice down to the area that needs to be relieved. So when they do that, it's not just a simple slice, we're talking a very large open area, They can do it in surgically, they can do it emergently, I've seen them do. But this is something that is going to require then once it's not something we can just stitch back up, right? This is something that we're going to have to really like work and heal with tertiary intention, where it's like inside out, sometimes even skin grafting, but it saves the limb. The next complication of a crush injury we're going to talk about is not always crush, but very common in crush. We'll talk about that. So this is rhabdomyolysis, and I forgot to put the extra O after the Y. So it's actually rhabdomyolysis. And that is where the cells in the muscle have ruptured and are leaking their contents. And when this happens in skeletal muscle, we release myoglobin. This myoglobin then will bind and clog up the filtration system of the kidney, which will then cause damage. So if you have someone who presents with very dark or tea or Coca-Cola covered urine, sometimes a change in mentation, some confusion, your first thought is going to be rhabdomyolysis. Now, a lot of times this is caused by trauma, right? Crush injury. It crushes a muscle to the point where it breaks down, but it also can be from strenuous exercise. It can be from exposure, hypothermia, be from a drug overdose. We often see this in elderly. And this is the elderly people who fall, who are left on the floor for a day or two until someone comes and checks on them. Between the fall and the lack of movement, they have muscle breakdown, and they very commonly will have early rhabdo. Okay. The other thing is going to be when we talk about strenuous exercise, we're not talking about like I went to the gym today. We're talking about repeated, strenuous, vigorous exercise that is damaging the muscle. So we're talking, people who are on the lacrosse team. In Cincinnati, there was a college who got a new college trainer for the lacrosse team, and 11 of the girls on the lacrosse team ended up in the hospital with rhabdomyolysis from muscle breakdown. So I want you to think about, and this is an example of opening up a box of spaghetti, right? And you see those spaghetti, that pasta is nice and straight, and you can bundle it in your hand. Everything holds its shape. When you damage the muscle to the point where it breaks down, it is the equivalent of cooking that pasta, and that spaghetti is actually unable to hold its shape, right? And that's what happens with the muscle. When we say it breaks down, we know that when we work out, right, we break down the muscle, we produce a little lactic acid, the muscle then rebuilds itself and it's stronger than it was before. We're not talking that. We're talking complete breakdown of the muscle. Because there's so much myoglobin, then the way that we need to treat it is to flush it. And we're not talking massive amounts of fluid. We're not talking about hypovolemic shock. We're talking about steady fluid administration consistently, making sure that we get that fluid resuscitation going, right? So lots and lots of fluid until we start to get better urine output, until it starts to clear, so the color starts to improve, and when the mental status starts to improve as well. Metabolic acidosis, we talked about with shock, and that is where we end up with an inability to remove the carbon dioxide from the tissues and a lack of fresh oxygen delivery to them, which switches our metabolism to anaerobic, which then we get our lactic acid, we get our high potassium, we get all of the things that go with that metabolic acidosis. The difference is if it is due to a trauma or a crush injury, we usually have the onset of mechanism, right? It's not like we've got some sepsis where we're leading into this metabolic acidosis. We can kind of track it from the onset. Usually, about 12 hours after the injury is where you're going to see the peak of this because of the way that the body systems function and the way that perfusion is interrupted. So just keep an eye. We need to kind of watch how it's going. So our therapeutic management, depending on what it is, we're going to look at all the electrolytes. We're going to look at the myoglobin. We're going to look at our renal panel, our lactic acid, definitely look at our ABGs. We're going to work on maintaining those interventions, the fluids, the wounds, the bleeding, making sure we're taking a look at what's coming, right? And where we've been to see if anything's elevating. And then very similar to what we did for shock. Are we doing crystalloids? Are we doing colloids? Are we going to manage the bleeding? Are we going to replace with blood products, right? All the different things we do for stabilization. Thoracic injuries are unique in that it is a crush injury, but we do have bone in there as well, right? So crush injuries with the compartment syndrome have to do a lot with the soft tissue in the muscle. This has to do with more the lung, which is an organ, and the ribs, which are bone, right? So the most common chest injury you're going to have is just a single rib fracture. And this can happen from a fall. This can be from a CPR. This could be from something where they're broken. And what happens is that there's a crack in that rib, right? When there is a gap in the rib and the bones do not line up, then you have a displaced rib fracture. The problem with that is that that sharp edge of bone then could either poke up or poke down, right? So it could poke into that pleura. What happens is the lungs are in a vacuum, and we'll talk more about the respiratory system, but when that negative pressure that allows the lungs to expand and collapse is punctured, it's like a balloon, right? You puncture it and it just contracts. So we can end up with a hemothorax. Also, depending on where it is, it can actually puncture into your vessels or it could go into the soft tissue of your organ, like your spleen or your liver, which could be a secondary issue, obviously. With rib fractures, a lot of times we have pain on deep breath. That's kind of our main indicator. They might have some diminished breath sounds if there's a pneumothorax. Also, they may not want to take a deep breath because of the pain, right? It hurts. So we just take shallow breaths so that we don't have to expand our rib cage and cause more problems, which can lead to, again, atelectasis and things like that. If we understand what a pneumothorax is, right, we're gonna have an absence of breath sounds on the one side. So just making sure we understand what the ramifications are from a broken rib and why it can be a big deal. This is flail chest. I will let you click on the short. I showed it in class. I'll let you look at it. But what this is, when you have your rib cage, right? So say you have a break in these three ribs here. So if these are cut off, right? As our chest expands, this is actually going to suck in. And as we contract, this is actually going to pop out, right? We call that paradoxical movement because it's a free floating chunk of rib that basically does the opposite of what your lungs are doing because that pressure is just, it's not connected, right? The ribs move and it just kind of does its own thing. So when we see this, again, medical emergency, we're going to try to hold pressure on that free floating section because the more it floats and moves around in there, the more it's causing damage. Every time it goes in and out, it's causing friction, right? So if you see flail chest, trying to compress it to make sure that we minimize damage and obviously respiratory support. But the hallmark is you're going to see that side of that paradoxic chest movement, unequal chest expansion, something that we call crepitus, and that's as we are moving with that rib section. Free air is kind of getting trapped under the skin as the lungs kind of move past. So pressing on it is going to feel like if you take a baggie and you fill it with Rice Krispie treats and you kind of put your fingers on it, that's exactly what it feels like. But it's subcutaneous air that gets trapped in the skin and muscle tissue, not in the lung. Also, they're going to have terrible shortness of breath, difficulty breathing, and you may notice some crackles when you are listening as well. So, rib fractures, flail chest, which is a type of rib fracture. The other thing we need to pay attention to is a pulmonary contusion. So this is sometimes we see it with the chest trauma, with the flail chest, with the broken ribs, but more often than not, we're going to see this as it develops. So we're not going to even see this right away, but it's caused by the lungs being abruptly compressed and decompressed. So what that does is it crushes internally the alveoli, all the little blood vessels in the lung. They start to bleed and swell and get inflamed internally inside the tissue. And what happens over time is that lung becomes less compliant. The blood flow is interrupted and it becomes more difficult to breathe. So a lot of times we don't see this until 12 to 24 hours after the crush, after the chest injury. So just because everything looks okay and the ribs are broken, but they're all lined up and it doesn't look like they're displaced, does not mean that the lung did not suffer an injury and you're going to see it going forward. So when you're caring for a patient and they seem like they're fine, or you're not really seeing much, but they start to begin restless, they start to get nervous and anxious, they're complaining of chest pain, worse with a deep breath, their heart rate goes up, maybe their oxygenation is going down, maybe they're coughing and you see a little blood tinge to the sputum as those vessels are ruptured. We need to act very quickly because this can lead very rapidly to acute respiratory distress. Okay, so we definitely, if we know that this injury has happened, as soon as we start to see evidence of it, we need to act. When we're looking at thoracic injuries as a whole, we do need to make sure we're taking into consideration we have to prevent any type of respiratory depression. So while we want them to be comfortable, we can give them medication. We're not going to sedate them to the point we lose our respiratory drive. Okay, we need to make sure that we are getting serial chest x-rays, we're using supplemental oxygen, we're really paying attention to changes in those respiratory system assessments. If they end up with flail chest or a pulmonary contusion, more times than not, intubation is going to be your key to maintaining good perfusion and oxygenation while everything heals. So our priorities for these thoracic injury patients are going to be pain management with a caveat that we are not going to allow respiratory depression with sedation. We're going to make sure that adequate ventilation, we're going to make sure good air movement, and then good gas exchange, right? So those are the things that we're really focused on. If they're not intubated, this is coughing, this is deep breathing, this is suctioning, this is making sure that we are promoting expansion the best we can. If they are intubated, obviously that's not going to be a thing. We could still suction though to make sure that everything is as clear as possible. Any changes, right? Any changes in the breathing, the work of breathing, any lung sounds, fever, vital signs. So anything that you think, I don't know, grab a friend, grab a charge nurse, grab the supervisor and say, hey, this is what it looked like before. Here's where we look now. And then definitely let that provider know, because if you can catch it early, there's a much more positive outcome. Last thing I want to talk about is promotion, health promotion. How do we prevent trauma like this from happening? Motor vehicle safety, this is where we teach our kids, right? Don't use your cell phones, don't drive if you're tired, don't drive if you're under the influence. Making sure if you're on an ATV, make sure if you are on a dirt bike, right? Helmets save lives. Make sure for the home, we are talking about fall prevention, pool safety, burn prevention, getting rid of ice in the wintertime, right? For our farmers, they're around a lot of chemicals, making sure they understand how to use them and store them safely, use of heavy equipment, making sure that we are, not leaning over to try to undo the combine. I know it's hard to like get down and do it, but maybe if you reach over, but your arm gets sucked in, so the things that they need to know. Workplace safety, OSHA guidelines, they're there for a reason, right? I know it's easy to bypass, but they're there for a reason. And then our relationship and communities. We want to make sure they're safe, make sure the street conditions are good, make sure that we are aware of different types of abuse, right? That might lead to future trauma and intervene early. So these are the type of things that are important. So hopefully this gives you a little bit of an idea. We're going to continue to talk about mass disasters, bioterrorism, those type of things in another little micro lecture. But this hopefully gives you an idea of how to complete a survey, primary, secondary, what to look for, and treatments and interventions.